understanding. If you want to give it some time, I think they want to do it right. Good morning, everybody. Welcome to Grand Rounds. I'm very pleased to welcome you all here today. We have a very special speaker with us, Marianne Parshley, who is the current governor of the Oregon chapter of the American College of Physicians. Dr. Parshley did her undergraduate and medical school at Dartmouth College, and she completed her residency right here at Providence, Portland. And she has been a primary care physician at the Gateway Clinic just down the street since 1993. She's been involved in a number of ACP chapter activities over the years. She was the co-chair of the Oregon Chapter Council of Women Physicians. She's served as an advisory board member, an Oregon delegation participant at Leadership Day for many years, and Governor's Advisory Board, Oregon Chapter Governor Nominating Committee. She's been involved with ACP national activities, serving as a national advocate for internal medicine for the past decade. And she's had so many other committee and leadership involvements, including with the Oregon Medical Association, the Metropolitan Medical Society of Portland, and countless others. On a personal note, Dr. Parshley was one of my favorite people to work with during my time at the Gateway Clinic. She models a physician who is exceptional, thoughtful, cares about the whole person. And she role modeled enriching your life and career through advocacy as a way of staying active, engaged, and avoiding burnout. And I was always glad at our staff meetings she would come and give us updates on the issues that were important for the ACP at the time. And so we're inviting her here to talk about physician advocacy and initiatives that the Oregon chapter of the ACP finds important right now. Welcome, Dr. Parshley.
Thank you, Jesse. Talk about favorite people. We were really sad to see Jesse leave, but we're happy that he's instructing the next generation of internists. Last time I gave Grand Rounds, it was not in this room, it was over in the other building. It was 1987 when I was chief resident, and I think I talked about retroviruses, and I have no idea what I said. This is something I'm much more passionate about, which is physician advocacy, and it is a source of well-being for me. If I can figure out how to work this. No, I didn't want to do that. I do have no monetary disclosures, but I do have the disclosures that I have some interests. One is that I'm the governor of the ACP chapter, but I also sit on the board of governors, which is responsible for developing policy for ACP National. I sit on the medical practice and quality committee, which is one of the two policy generating committees of ACP National. And I recently joined the advisory group to improve documentation to enhance the EHR, which is an attempt to take the new rulemaking regarding E&M coding and see if we can make documentation burden less. I'm also the vice president of Oregon Medical Association, and I sit on the executive committee and the board of trustees there. And I belong to both their PACs, which is important, but I won't talk about that. So goals of this talk, one is to understand why healthcare provider advocacy is important, in particular physician advocacy. Understand the avenues available to us to be able to share and augment our voices in Washington and down in Salem. An overview of some of the important issues for ACP National, Oregon ACP Chapter, and also the OMA. And a few tips, if I get to it, for healthcare advocates that I've just picked up, which may or may not be valuable to you all. So why physician advocacy? I think I first became interested beyond, getting a little passionate about something and sending a letter to my senators when I went on a Providence delegation down to El Salvador in 2004. And we, as part of that delegation, went to the embassy and we're trying to advocate for an 18-year-old gentleman from the community that the sisters were operating in. He was bright. He wanted to get out, get education, and come back to his community so he could serve them. And we went to the embassy to see why his visa kept getting denied. And then we stood in front of us stood a very well-groomed young woman who explained to us it was much more likely that an old woman with a treasured chicken in her yard would be able to get a visa to the U.S. than this young man who had a full-ride scholarship at a major American university and wanted passionately to go back and make life better for his people. And I thought, there is something really wrong beyond medicine, and we need to sort of figure out a way to fix it. So I can't think of anyone better to express it than Don Berwick. He says to try to avoid the political fray through silence is impossible because silence is now political. You either engage or you assist the harm, and there's no third choice. So I think of it as a professional responsibility. Oh, that was my last Providence thing. I'm taking the Providence hat off at this point. And that becomes, the hats become important, as you'll see at the end. I think of it as a professional responsibility to make the lives of our patients better and the lives of our colleagues better. It's also to share our expertise, because there's no one at any level of government that has the expertise we have in healthcare. There are people who have healthcare administration expertise, and they are out there. Trust me, Providence has got a great governmental affairs department, and they do a great job, but our perspective is needed. And we can participate in the dialogue about the future, about the transformation of healthcare. It's ongoing and has been as long as I've been in this for 30 plus years. We want a just, equitable, and affordable healthcare system, high value too. We want our patients' well-being to be considered, not just the medicines we give them and the diagnoses we made, but their lives to be better. We want to preserve the physician-patient relationship. That's the trusted relationship between patients and physicians, and there's continuous attempts at eroding that. We improve the community health, safety, vaccines, clean water and air. That's important. And we want to take care of our colleagues. Not just do we want people to get good and sustainable compensation, but we want the system to have reduced burdens of administrative burdens so that we can live a life and also enjoy ourselves while we practice medicine. And then there's specific issues. This is my current list of issues. I'm not going to go through it with you. I was going to try this really cool tech trick and get all of your issues, but it didn't work in the translation between Mac and PC. A quick side trip into civics, because I use this as a way to think about how I can impact things. And there are certain people tweeting at 4 a.m. who don't seem to have an understanding. 3 branches of government. The legislative, I think we all think of that as the place advocacy happens. But the executive branch is also important. And so is the judicial, and that's the one I always forget. And there are different levels. There's the local, there's the regional like Metro, there's the state level, and there's the federal level. So the legislative level, obviously they make laws. That's why we go to Salem, we go to DC, and we talk to our congresspeople. We're trying to sway or at least tailor some legislation or encourage them to sponsor legislation. They also fund the agencies and the programs, which I didn't realize was a 2-step process. They not only have to authorize funding, but then you have to go back and appropriate it. And a lot of times you have to appropriate it every year. So the whole battle over CHIP, the Children's Health Insurance Program, was about reappropriating money for it, reauthorizing and reappropriating. Fortunately, last spring, they finally passed a law that did that for the next 10 years, so we can take that off our agenda for a while. The executive branch, they run the agencies. They implement the laws, and they make regulations to implement the laws, and they distribute the funding. So they can choke off funding to one particular agency they don't want to fund and they don't believe in, and they can give a lot more to another. They also provide leadership. So some of the agencies that we need to work with are CMS, Health and Human Services, the Office of the National Coordinator of Health Information Technology, ONC, and the Oregon Health Authority. And there's the judicial branch. This is really important, and I always forget it. They not only do the constitutional review of laws and regulations, they also adjudicate on violations of the statutes. And that's become really important in the last couple of weeks around Title X. So who is it? all healthcare workers should be advocates at some level or another, whether it's just voting or it's getting more active. Physicians and physician assistants have great national organizations, and in Oregon, they're represented by the Oregon Medical Association, primarily down in Salem. The nurse practitioners and the nurses are well organized, and in Oregon, they're very good at lobbying. Allied health professionals, from social workers, case managers, RTs, pharmacists, you can go down the list, and administrators. And again, they do a great job. I trust Providence's governmental affairs department to do it, but we're not going to talk about that. So where do we do it? First is the individual level, and I'll talk a little bit more about that. The next is the clinical hospital health system level. If you're an employed doc, that's really in the hands of the health system. If you're an individual or you have your own private practice, like say the Oregon Clinic or the Portland Clinic, that becomes more important. And what I'm going to mostly talk about today are the professional organizations. So ACP, OMA, AMA, family practice, and so forth. What do they give us? Well, they give us an opportunity to participate as members, both in policy development and in advocacy, and how that's expressed. It gives you an opportunity to serve in leadership and be more impactful. And I think another important one that we forget is it gives you an opportunity to serve at a different level. So you can participate in work groups and task force and advisory councils, and that's often the doorway to doing that. For instance, the Oregon Health Authority called together the opioid task force that released guidelines on acute prescribing and chronic prescribing, and they're now actually calling, I think they're still calling for people to serve on a task force on tapering opiate medications. So how? As an individual, well, you can write, you can email, you can call, and if you do, make sure it's one issue, you're really clear about what you want, and that you tell them your constituent. You can use social media. I love Twitter. You can actually address things to the individual Congress people, and they will answer you on email, and trust me, they're counting that stuff, and you've heard it blow up in the news. You can give testimony, both written and oral. I've found that's become much more powerful. You can do this on rule generation by the executive branch and agencies, and you can also do it for legislature. And I'll show you later how you can do it in Oregon. Really important right now with the vaccine battle that's going on in Salem. You can organize. You can get a bunch of people together. That's how you had the Women's March. That was spontaneous organization. The pros are, you know it's your issue and your opinion that's getting expressed. That's the really important thing about individual advocacy. And you're powerful if you can bring a bunch of people together. The anti-vaxxers show us that. They're making huge noise down in Salem. It would be great if we had a white coat contingent that went down there and faced them off every time. And the people who are working in government know that this truly is their constituent's voice if you do it as an individual. The cons, it's hard to know if you made a difference. I mean, if you're one of or a small group, it's really hard to know if you made an impact, but I can tell you the battle in 2017 to avoid the repeal and replace legislation was really impacted by individual and small group testimony, like the little lobbyists, and on Twitter, Medicaid Matt, very powerful voices. It's also extra hard. You gotta do a lot of research, you gotta spend time, and it's all volunteer. So, I do some of that. But a single person can move a boulder, and an entire group can move a mountain. So how do we find the mountains? Well, it's kind of the vogue to quote Fred Rogers right now, but you look for the helpers. You look for the people who help. And I think professional organizations for physicians, PAs, nurses, et cetera, are really important. The policy is based on the member vision and the staff experience and expertise. Usually it comes from resolutions or ideas from members. It also comes from recommendations from committees that have been considering issues. Also, state and national staff might propose or be aware of an issue that members are not, and then bring that to their attention. The pros are there's powers in numbers. There definitely is power in numbers. You also get the expert lobbying coach. I can't tell you how much I've learned from the lobbyists at the OMA level and actually national level, but I think OMA lobbyists are awesome. Advice and organization, resources, time and money, and that comes from membership dollars. Potential door to serving in other ways, like I'm really enjoying my service up on the Medical Practice and Quality Committee. It's amazing what we discuss in that committee. And I think it really shapes the national policy and implementation. The cons are you don't have as much control over the messages. You have to decide whether that organization is actually voicing what you want to have voiced, and you have to give a little. They may say things on one issue that you don't like, but if the general message is good, then you go for it. And you have to pay membership dues, but you get a return on investment. So a little bit about ACP National. There are 154,000 plus or minus internal medicine docs, students, and residents, and some allied professionals, mostly PAs. I think there are a few nurse practitioners also. They collaborate with other physician organizations to raise that number. They started a group of 6 back in 2017 to respond to what they thought was going to be an interesting time in Washington around the Affordable Care Act. Together, the group actually numbers more than 560,000 docs, which is bigger than the OMA, but the OMA also collaborates. And this winter, they actually founded their own website, and they've started to go, the leaders in each of those groups are starting to go to Washington to talk to regulators and to the Congress together, and that has impact. So ACP has a representative governance structure. It starts with the chapters and then goes up. Talk about it in a minute. They have very experienced and expert staff. A little less approachable, I think, than the OMA, but they're really, really experienced. The Oregon chapter of the ACP, on the other hand, we have a little over 1,700 members, and we have a half-time executive director who's got a lot of experience and expertise, and then they have volunteers like me and like anyone who belongs. ACP generates their policy through a bottom up. Comes from 2 places. One, it comes from membership. They funnel it through the chapters, who then write resolutions on issues that are important to them and send them to the Board of Governors, and they're considered twice a year. It also comes from the policy committees and the councils. So the Council of Early Career Physicians and the Council of Residents and Fellows have actually brought resolutions that have passed the Board of Governors. The Board of Governors then passes it on to the Board of Regents, which is the fiduciary and decision-making body, and they decide whether it's a go or no-go. Most of the time it's a go. They may revise it a bit. Here are the national priorities, the big ones, but that's a lot. And some of it I have really no interest in and no expertise in. So these are the things I think that are really make me really passionate. A lot of it crosses over to the state. These 2 don't, the immigration and the Medicare payment policies. So I'm going to talk a little bit about those first, and then I'm going to come down to the state level. Medicare payment and documentation. I got to get my notes for this one. You probably all heard in July of 2018 that Medicare proposed a change in the Medicare payment system. It was supposed to revise the E&M documentation at the same time as it revised the E&M coding. It was going to collapse all of the codes. You'd have 99211s. That was fine. But number 2 through 5 was going to be collapsed into one, and they'd pay exactly the same regardless of what level of service it was. In return, they were going to allow us to only document at a 99212 level for everything. In other words, you didn't have to do that huge EHR note bloat thing that you see, that you scroll through. You only had to document those things that had changed since the last visit. Most physician organizations didn't think that was a trade-off. It wasn't going to be sustainable. It wasn't going to pay adequately for cognitive services. So during that 8-week comment period, every single physician organization and a lot of other healthcare organizations commented, and tens of thousands of docs commented. And I talked about testimony. That's one of those places where your testimony counts, sort of. The final rule came down in November, And that was all supposed to start January 1st, 2019. They were going to completely revise the payment system. It would have been chaos. They did add some codes. They added primary care codes and specialty care codes, but even those didn't bring the average general internist back up to what they would have been before in terms of compensation. So when they released the rule in November, all of that lobbying made a huge difference. They backed off from the January 1st, 2019 date, and it's now 2021, and they're still negotiating about all of that. They did continue to allow some transformation of the documentation, but I don't think it's going to really take hold. And they allowed things like expanded telehealth access and billing, and allow you to do easier time-based codes. But that's where ACP and others had real big impact. This one, the immigration issue, this is close to home because my son-in-law is on an H-1B visa from India. But I also have colleagues. One of the first people I traveled to DC with was from Lebanon, not Lebanon, Oregon, but Lebanon, the country. And she was here on an H-1B visa. She had to serve in a medically underserved area for 3 years in order to not have to go back home to Lebanon for 2 years at the end of residency before she could apply to come back to the US and serve. So she served in 5 different communities in the state of Oregon, all small hospitals, before she was able to get enough time, make her way out of that and get a longer term visa. Now she's a critical care, infectious disease, pulmonary care, triple boarded specialist working in Florida. There have been H-1B and J-1, which are the visas that medical people have, delays over time. And they only allow, in order to get into the longer permanent residency visas, they only allow 7% of the total number to come from any one country. The vast majority of medical people who come into the country, physicians, residents, medical students, come from 2 countries, India and China. And so the delays on those people getting green cards are decades long. They told my son-in-law it was going to be 15 years before he could get a green card. So he finally agreed to do it through getting married. Yeah, that was actually a big battle. Separation of children and families at the border. This comes through ACP policy in a number of ways. I remember I was actually on the Camino de Santiago on sabbatical last summer when this blew up. And I hadn't checked in with the internet, and I hadn't checked in with the news, except in bars where we were watching, the World Cup soccer. And all of a sudden I saw Jeff Merkley, our senator, on the TV with subtitles in Spanish talking about the separation of kids and families at the borders. ACP strongly objects to that. And since the death of 2 kids in ICE custody, they're really pushing hard to investigate the conditions and to make sure that that goes away. It's actually in violation of a court decision that said that DHS can't separate children and families without excellent reason for more than 20 days, and they're certainly doing that. And the Dreamers, the deferred action for childhood. I can't remember what the last A is. What? Arrivals, thank you. These are folks who didn't have a choice. They came to the US. They're US citizens in their hearts. They've been educated. They're a lot in healthcare. They're in first responders. They're in ERs. They're nurses. And if they leave, the healthcare system will be devastated. But more importantly, it's a matter of justice. So ACP is on the forefront of commenting and urging the current administration to back down on their rescinding of the DACA program, and they're working hard in that level. And the public charge rule change. I don't know if any of you know about the public charge rule change. The current administration proposed that that if any legal immigrant, people who are here legally, used any kind of public services, including Medicaid, Medicare, housing subsidies, or food stamps for their family or themselves, that they would no longer be eligible to get permanent status green card status, etc. Most of the major medical associations have opposed that. I still haven't, I'm not sure where that stands. So the others in white, the other issues in white, I'm just going to touch on really quickly. Coverage. ACP's been on the forefront to oppose repeal and replace legislation because most of it wasn't just and equitable in any way. More importantly, in the last year, they've been really pushing to stabilize the insurance markets. There have been a number of pieces of legislation at the national level intended to stabilize that and doing things like returning or fixing the cost-sharing reduction payment program and the premium subsidies. And I could get you information on that if you want it, but I'm not sure I understand all the ins and outs. Also to avoid the erosion of the 10 essential health benefits. You know, the ACA said you have to pay for doctor's appointments and it has to cover ER visits and medications and lab tests and so forth. There's been a lot of work on the regulatory front by this administration to try and get rid of that for some things, including trying to push 2 different kinds of short-term, less expensive insurance. I think one's called an association health plan, and the other's a short-term duration health plan. They're much cheaper, but they don't cover the 10 essential health benefits. And they also don't protect you from pre-existing condition rating. So working really hard on that. And then also sustaining and keeping the Medicaid expansion. I think it's 36 states expanded Medicare over the last 2 years. Oregon's one of them. And there are 14 who didn't. So trying to encourage those states to do it. But there's also been efforts to erode that by some states like Kentucky requiring a proof of work for those who get Medicaid. 60% of people who are on Medicaid actually work, either full-time or part-time, and 80% of them live in a family with at least one full-time worker. So it doesn't quite make sense. All right, reducing firearm deaths and injuries. Comprehensive background checks, that's perpetually there. Oregon's way in front, so I'll talk about that later. They also want to close the loopholes. Oregon's been closing the loopholes for at least the last 5 or 6 years. They want to return the funding to the CDC. This cute little thing that happened in the late 1990s was they had an amendment to some funding bill which made it suggest that the CDC couldn't study firearm injury and death, that it was against the law to do so. And at the same time, mysteriously, they cut the CDC funding by exactly the amount the CDC had been using to fund that research, $50 million. And that's never come back. Last spring, they finally said, oh, that Dickey Amendment, that didn't mean that you couldn't study it. You can go ahead and study it. But they didn't return the funding. So right now, there's a push by ACP, AMA, and a lot of others to restore that $50 million to the CDC so they can actually do it. Child access prevention laws, safe storage of guns and ammo, and allowing sellers and states to put a age 21 limit on particularly assault weapons, but any kind of weapon if they choose. They want to ban on the high-velocity, rapid-fire assault weapons and the large-capacity magazines and the bump stocks. I'm amazed at the conversation out there on social media about what an assault weapon is and what a rapid-fire weapon is. I get completely lost in the details. But the fact is, the guy in Las Vegas killed a lot of people with those weapons. And so there's got to be some definition and some way to keep those weapons out of the hands of people like him, while preserving the Second Amendment rights for those who want to use them for hunting or sport shooting. And extreme risk protection orders. I think Oregon already had one of the first in the country. But if somebody's more likely to use that to kill themselves, and the majority of firearm deaths are suicides, or to use it on others, either others they don't know, like the Columbine shooting, or more importantly, in intimate partner violence, that they can be removed by the authorities. Climate change, public health issue. Firearms are a public health issue. Climate change is a health issue. Its impact's greatest on those people in areas with the lowest resources. So ACP is calling for clean air, clean water, reducing carbon emissions, et cetera. They have a toolkit on the website. That's pretty good for those who want to bring that down to the clinical level where they're practicing, but they're also advocating at a national level. Drug pricing. The best I can say is this book, An American Sickness by Elizabeth Rosenthal, the subtitle is How Healthcare Became Big Business and How You Can Take It Back. This is a revelation. It's an easy book to read. I lived through the period she's talking about, and she brings it up to today. I am stunned at the kinds of things that go into the rising cost of prescription drugs. It's well worth a read if you want. ACP National is also asking for that, and I was just in DC in February for AMA advocacy efforts, or days, or whatever, and they're also talking about drug pricing and prior authorizations and the fail first step therapy. And in Oregon, we're working on transparency. If you raise the drug price by 10% or more, why are you doing that? What is the cost that's going into that that's causing you in 1 year to raise the price of a drug more than 10%? Women's healthcare, ACP National had published 2 papers this last year. One was on women's healthcare and one was in women in medicine. Basically, ACP National wants to ensure that women have access to affordable, evidence-based, comprehensive healthcare throughout their lifespan, including reproductive health, and without gender rating. Because before the ACA, if you were female, you were charged more for your health insurance in many places. They want to protect and retain the current benefits and coverage for women, including preventive health care. And that means comprehensive reproductive health clinics, which means access to abortion, or at least the right to talk to your patients about abortion. They want to protect Medicaid funding. They want patients to have autonomy in the decision-making about their reproductive health. And that means teenagers who've declared themselves adults so that they don't have to go back and get their parent permission. Women don't have to get permission from their husbands to make decisions like that. Title 10, I'll talk more about in a little bit. It's about preserving the freedom of speech for physicians. And women in medicine, more and more over the last 5 years, papers have been published showing that women in medicine make 70 cents on the dollar compared to men. They are present in leadership positions far less than men. And they're not safe from the Me Too stuff, the violence and the sexual harassment and assault. So ACP's got policy on that, and I'm not going to talk more on that. It's got a great web page if you want to go to the website talking about it. Now, ACP Oregon. We have policy priorities too, and we base them on members' issues. So people get passionate about one thing, they bring us an issue, we'll talk about it. The committee, the Health and Public Policy Committee, considers it, reviews the ACP policy from national, and makes a recommendation. We collaborate with other organizations like the Oregon Family Practice Docs and the pediatricians and Oregon OBGYNs. And the Governor's Council has to review and approve any policy decisions we make. If ACP National has policy, we have to follow that policy. That's part of our charter. If ACP doesn't have policy and it's a statewide issue, we can make the decision on our own with the Governor's Council. So in 2018, we did a bunch of stuff. In January, you probably remember Measure 101, where they'd passed a Medicaid package in Salem, and one legislator put it on the ballot as a ballot measure to vote it down. There was a big coalition of people talking about it, and we helped pass Measure 101. Vaccines. In the gubernatorial election in the fall, one of the candidates made a comment that he could not support removing non-medical exemptions for vaccines. And that became an issue for the Oregon Academy of Family Practice, and we joined in a statement on that. Housing, Measure 102, we endorsed Measure 102, which funded housing, affordable housing with wraparound services, because that's a social determinant of health. And we also opposed Measure 106, which would have limited the access to comprehensive reproductive health for women, i.e. abortion. And then Pittsburgh shooting happened. That deeply impacted some of our members. I heard from them almost instantaneously. So we felt like we really had to make a statement. National ACP has a policy recognizing that hate crimes are a public health issue. That came from the Residents and Fellows Council. They're a pretty awesome group of young people. So we spoke out. And we published both on Facebook and Twitter and Instagram a statement about the shooting at the Tree of Life Synagogue. Shortly after that, ACP issued a revised revised policy on reducing firearm injury and death. I'm trying not to say gun violence. And then the NRA got into the act. And they tweeted out this nice little thing that told doctors, hey, you need to stay in your lane. This is none of your business. And there was an outpouring of physicians. Tens of thousands of physicians commented on that with pictures of ER scrubs soaked with blood and stories about patients that had suffered from violence with weapons. So we published a joint statement based on the ACP policy and a couple of op-ed pieces written primarily by our chair of the Health and Public Policy Committee, Adam Obley, who's at OHSU, and the Evidence-Based Center for Health Policy up there. And then I got one in the Statesman Journal. So that's another avenue for advocacy. You can do op-ed pieces. You can write letters to the editor, especially on really important and hot topics. So our 2019 priorities were based on the HPP recommendation and review, and they are as follows. One, supporting the Medicaid funding in Oregon. It's important to support that. We get federal dollars based on how much the state puts in. The governor's budget's pretty good on that, but there was a missing piece. There was still a gap in the funding, and that we hope to get back by a tobacco tax. The tobacco tax will actually only bring us up to the tobacco tax of California and Washington by adding $2 a pack. But the other thing that I think is really important in a public health way is that we will now, we hope, if we can get this passed, put a tax on e-cigarettes and Juuls and vaping. And that has two purposes. One is it will keep young people, hopefully keep young people from smoking and nicotine products at a young age, because it's really cool to have a Juul in your pocket or in your backpack and sneak it while the teacher's talking in the front of the room. And they also have twice as much nicotine per dose as a cigarette does. The second thing is it will help fund Medicaid and education against tobacco products. Climate change, we decided we'd jump on that because House Bill 2020 is a cap and invest bill. It will tax carbon emissions above a certain level, and then that money will go to the state, hopefully to work on education, to reinvest in clean energy, and hopefully also for healthcare. And there's a number, we found this out on March 5th. There's a number of bills in the Oregon State Legislature having to do with firearm violence. One is HB 2251. Hang on. Basically, it's the same things. It's, let's see, it covers the loophole, the final loopholes in background checks. One of the, I don't think this bill does it, but one of the bills will allow institutions like the state capitol and public schools to prevent people coming in with concealed carry. There's one that will raise the age of having an assault weapon to 21 or above. And there's a safe storage of weapons and ammunition. I don't think they're all encompassed in that, but it encompasses most of them. And Ginny Burdick, our senator from the west side of Portland, who is the Democratic majority leader in the Senate, has been working on this since 2008. We sat down and had a talk with her on March 5th. She's impressive. She said she knew she couldn't get it all at once, so she's just been chipping away at it every session since then. Prescription drug pricing, there's several bills related to this in Oregon, and most of it has to do with the transparency that I talked about. If you're going to raise the cost, you need to justify it. Tell us what's behind that what's in that black box. It's not just research. There's marketing in there, and there's profit in there. So tell us what's involved. So collaborations, we talked about collaborations, and now I'm going to put my other hat on, which is the OMA hat. Oregon Medical Association. It's still the primary voice in Salem for physicians and physician assistants. They've been there a long time. They're well respected. They have a lot of relationships built. That's much bigger than the ACP Oregon chapter with 6,600 physicians, 750 physician assistants, over 1,000 medical students, and PA students, and more than 500 resident physicians. You can see it breaks down, but internal medicine's at the top, which I'm very proud of. Primary care is the biggest block. And what really pleases me is that about 60% are under the age of 55, so I don't count, and 33% are under 40. Yes, I mean, we need people coming up to do this work. OMA policy development is simpler than ACP. It starts with resolutions that are crafted because people come to OMA with an idea like housing and homelessness. I've seen things come up for, there's one, I'm working with 2 medical students who really want to do it on intimate partner violence. There's firearms stuff, there's physician aid in dying that seem to come up. The OMAs, then they're posted on the OMA website. OMA members are allowed to comment. Then the reference committee pulls all the comments together, makes recommendations, including revisions. And that's then given to the Board of Trustees to review, and they make a final decision. Sometimes they accept the reference committee recommendations, and sometimes they completely reject them. And I was chair of the reference committee for a couple of years, and I couldn't predict. So the value of advocacy. OMA believes in implementing health system reform in a logical and physician-friendly and patient-friendly way. They also are addressing some workforce challenges. As you know, we got a physician shortage coming up, particularly in rural areas, so they're always looking to get extra money and grants for rural physicians. They want to improve public health and prevention and wellness for physicians, and they want to improve the Oregon practice environment. So that also means liability reform, insurance reform, administrative simplification, and sometimes deal with scope of practice issues. But that's not all. We've got 2 lobbyists and a couple of other people supporting them, and they interact with all of those committees. Oh, I think I have look at that. On the House side and the Senate side, and there are also joint committees that are on this. They're tracking currently, I think, over 800 bills. This says 600 because it's from a couple months ago. They manage 22 legislative days, and I've watched them. They sit with their cell phones answering things all the time. They participate in governor and legislative work groups and task force, and partly by drawing physicians into that. They maintain relationships with 90 legislators. They work that Capitol building really well, and hundreds of staff. And I'll come back to staff at the end. The staff are key. And they're monitoring the Rules Advisory Committee and the Oregon Administrative Rules. So some recent highlights, successes for OMA in the last couple of years. 2 years ago, they passed a piece of legislation creating a maternal mortality and morbidity review committee. The U.S. is shamefully behind other countries, developed countries, in maternal mortality and morbidity, particularly if you're a woman of color, and we don't have any data. So just getting the review board to look at every delivery and every death is important. They expanded the Oregon Psychiatric Access Line from kids to adults. That just went live in October. They got $10 million in additional funding for rural provider workforce incentives. They have passed legislation regarding the PDMP. They successfully fought off the DEA's attempt to access physician data from the PDMP. They've stopped attempts to remove caps on non-economic damages. They secured the governor's veto on psychologists prescribing, whether you believe in that or not. They did it. And they raised the legal smoking age to 21. This year, March 5th, we went down there and we lobbied again under their direction. And they have a bill called the Utilization Management Transparency Act that works about utilization management, not so much as to prevent it or tailor it, but just right now to make it transparent. So when you're talking to an insurer about why they will or will not approve something or doing a peer-to-peer review, you can at least see why they're making decisions and how you have to tailor your presentation. House Bill 3063 removes the non-medical exemptions for vaccines for those who are whose kids are going to attend public school. Public school vaccination rates in the state of Oregon are lower than the national average. They range from 98% to 40%. 40% of kids in one school in Clackamas County are vaccinated. And with the measles epidemic in Vancouver amongst the unvaccinated, we know that's a big issue. They've been trying to get something like this passed a couple of sessions ago. One of the legislators who was a physician introduced a piece of legislation. She got phone calls on her personal phone, and family members got phone calls, and they threatened her and her family, so she pulled back on it and said, okay, we're not going to go for the non-medical exemptions. What we're going to do is have every school in the state publish what their vaccination rate was, which is why we know the 40 to 98% number. This time they think with the measles epidemic there may be enough political will in the building. I'll tell you what, I submitted testimony and the OMA submitted testimony, and there was live personal testimony on the 20th of February by physicians. The anti-vaxxers are much more numerous. There's far more testimony from the anti-vax community, and they're out in front of the Capitol with their kids, and they're haunting the halls. If we could get a white coat contingent down there, anybody who's interested, this is going to the Joint Ways and Means Committee, and written testimony will be taken once they've scheduled a hearing. If you want to go down and testify, you can talk to the OMA, they'll help you. I believe in vaccinations. I don't want my kids in public school exposed to things that are vaccine preventable. I have a young friend who got his kidney transplant at age 4. He had to leave school whenever there was some epidemic stuff going on. When he finally got chickenpox, he was in the hospital for 4 weeks. He almost died. I talked to a young colleague down there whose brother had childhood leukemia. Same story. He was actually in the hospital 2 months. So we need community immunity. We need 93 to 95% to protect the people who have no choice because they can't get vaccinated and are vulnerable. The anti-vaxxers are framing it as loss of choice. They have a choice to vaccinate their kids or not. They're not forced to. But if they're not vaccinated, they can't attend public schools. Sorry, I got a little passionate about that. Increasing the tobacco and nicotine tax, I talked about already. And there's also a bill from the Oregon trial lawyers trying to remove the cap on non-economic damages for torts, which include medical liability but are beyond that. There was a court case called Horton a couple of years back that allowed that cap to sit at $500,000 for non-economic damages, regardless of whether it's negligence or bad outcomes for whatever reason, or it's deliberate injury. So they don't think that's going to pass, but we still need people down there and writing. There was also, in terms of liability insurance, there was OMA participated with the Oregon trial lawyers and a number of different stakeholders about 2-3 years ago to come up with a piece of legislation designing a system called early disclosure and resolution, which around the country has actually been favorably reviewed by patients, by physicians and actually by attorneys. So that's just getting off the ground. And the OMA is asking that they not touch the cap until they see that that process and that culture change happen. There's also apparently a court case that will test this as well, and I don't know the details, but anyway. So, OMA and the courts. This is the only place I really touch on the courts, but I could talk about the gag rule in Florida on not being able to talk to your patients about gun safety, which the Florida State Legislature passed, and then immediately the Florida State Medical Association and one of the ACP chapters down there and a number of other stakeholders filed suit. It actually got up to the 11th Court of Appeals and was overturned. So OMA and the courts. I referred to the Horton case. That's the Oregon Tort Claims Act constitutional challenge to the damage limits, and that's where the cap came from. The Oregon PDP and the USDEA, I talked about that. They successfully fought back their access to the PDMP data. Smith versus Providence, I don't remember the details, but it actually introduced a new negligence claim, not just for injuries and non-economic stress, but also for loss of chance. So if the loss of chance of health, loss of chance of productivity. The Swank and the Valley versus Valley Christian School regarding physicians' liability across state lines. I believe that there was a Idaho physician who released a kid to play, if I'm remembering correctly, and the kid got a head injury in Washington State, and they sued in Idaho, and I can't remember the details. And OHSU versus the Oregonian Publishing Company about release of protective health information. Oregonian lost. And as of a week ago actually, the new Title 10 rule, all of the healthcare organizations in primary care, the AMA, and many of the state medical associations have been talking to the administration about not doing this rule change. They went through and they very carefully changed word by word to shift burdens and emphases in the Title 10 rule. Title 10 is the program under which reproductive health care is provided to low-income people, primarily women. It's never funded abortion. It's never paid for abortion. But the new Title 10 rule strengthened that abortion prohibition by preventing physicians talking to, advocating for, informing, or referring to anybody who provides abortions, whether or not they're going there for abortion. If they provide abortion, you're not supposed to do it. It also separates out for comprehensive women's health care centers that do provide abortion, it mandates that they have separate bookkeeping, finances, and physical space for the abortions, which will put many small town, rural comprehensive health care clinics out of business. And then one particular insidious one is that it requires physicians to pressure teens who are pregnant into getting their parents' permission to access reproductive health, which, if they're going to act like adults, anyway. And there are a lot of reasons that kids, anyway. So not only are states joining in a lawsuit, but the AMA and the OMA are suing the government over this, primarily on First Amendment rights for physicians and to protect the communication between physicians and patients. It was filed March 5th, 10 a.m., 2019. They dropped the new rule on Monday, March 4th. We were all down in Salem March 5th, and they filed the lawsuit. The other parties, in addition to AMA, are the Planned Parenthood Association of Oregon. So, if we have time, I'll spend really quick. I'll run through some physician advocate tips. First of all, be clear on who you represent at each issue, each moment, and each medium. So that's why I was talking about the hats. Am I talking for me? I'm not talking for Providence because I don't think I have a right to. Am I talking for the OMA or am I talking for ACP? All of these people are ACP folks. They're from Oregon or across the country. This one here is former chair, just stepping down as chair of the Health and Public Policy of ACP National. She's from Texas. Here's Tom Cooney, former chair of the Board of Governors, and he's up at OHSU. You know, John Masternardi. This is a friend who's ACP and a geriatrics professor in Long Island. All of us on there say, my opinions are my own. I'm not representing anybody but me. So advocacy is about relationships first. You want a longitudinal relationship with your legislators, your regulators, and particularly their staffs. So I have a hat that says wag more, bark less. I think that's important because if they're helping you on one issue, they may be on the other side the next time around. If they're opposing you and they're on the opposite bench this time, they may be sitting in your locker room next time. Legislative staffs. When I first started doing this in Washington, I was stunned that we couldn't talk to all our legislators. Well, we have an appointment with them. Well, we ended up talking to their legislative aides, and I have come to see that the legislative aides are the important people to talk to. It's great to talk to your legislator or your congressperson, but the legislative staffs are the ones who are doing the research. They're frequently writing the laws. They're definitely counseling and advising their member of Congress. They're really sharp people, way smarter than me. Be well informed. So check the professional organization websites about the issues. If you're there with a professional organization, they'll give you handouts and information and talk to you before you go up to the Hill. Google it. It's really a powerful tool. You can find a ton. And in Oregon, you can OLIS it. The Oregon Legislative Information System is great. You can just type this in. You can have access to committees. You can have access to issues, access to specific bills and to people. And as an example, my vaccine bill that I'm pushing, you can see who authored it. Oops. You can see who authored it, who are the secondary sponsors. You can see where it is in the process. It had a public hearing. It's now got a work session scheduled. And you can see what the next thing up on the docket is. And that'll help. And you can actually sign up for email updates. Don't make stuff up. You know, if you don't know, tell them you get them the information and then you do it, but don't make stuff up. Decide carefully where you want to put your political capital and your energy. This can be exhausting stuff, and I tend to go, I want it all. But if you pick a couple of issues that you can be well informed about, you can stay informed about the process, then you can have impact, real important impact. And don't exhaust yourself. Although I have to tell you, this is really, because it gives you power and voice, it is a real key to well-being, in my opinion, or for me. Smartphones. Smartphones are great, but they should be non-functional in any meeting you have with regulators or legislators or Congress people. Put them in silent mode. You can use them for a camera because they all want to have their picture taken and you want your picture taken. But they're also really important between meetings. We have heard about legislation in meetings and gone, oh, I never heard of that. You get on the phones and somebody finds it, and you can read the new bill and you can figure out whether it plays a role in what you want and your issue. So they're important, but you got to use them strategically. Business cards. I never thought I'd ever have a business card other than the one that gave the next appointment. But I've come to see that those are really important in the capitals. That you hand out the cards, they'll hand you their cards, it's information. I keep them, I make notes on the back of them. They're really important, and I finally got my own business cards. And thank you notes addressed specifically to the elected official. If it's important and you're sending an email, you can copy the legislative aide, and I think it's probably a good idea because they're more often the ones who will answer you. But the thank you note should be written and addressed to the elected official. And I strongly, strongly suggest you consider joining one of your professional organizations if you don't. ACP is my professional home, but OMA in Oregon is also my professional home because they have the voice in Salem. They provide you for your dues, they provide you voice, they provide you support, they provide you expertise, and they provide you with opportunities to serve on committees, to testify in front of Congress people in congressional meetings, and to serve in leadership. And I think that's important. And for young people, it's a great way to get leadership experience. So I'm going to end with Don Berwick, even though he is a pediatrician. The work of a physician as a healer cannot stop at the door of the office, the threshold of an operating room, or the front gate of the hospital. The rescue of a society and the restoration of a political ethos that remembers first to heal have become physicians' job too. Professional silence in the face of social injustice is wrong. So thank you. I hope I haven't bored you with my passion.
It's 9 o'clock, doesn't need to leave, Ken, but we'll stick around for a few minutes for questions.
No questions.
Hi, that was great. I'm a public health person,
Mm-hmm.
prevention doctor, and one thing that you didn't mention in your talk that is a real issue here in Oregon is the lack of funding to public health. With the Robert Wood Johnson Foundation several years ago, during the Obama administration, ranked Oregon 47th in the nation for per capita funding to public health, and we're lower than that now. We just don't have the data. There's in the governor's budget, there was an effort to address a longstanding thing called public health modernization. My understanding is the Ways and Means Committee has basically zeroed out that funding. The health authority is thinking that they might be able to tap into some of the tobacco tax money if
For
it
public
gets
health.
passed.
Yeah.
But I would really appreciate OMA and the other organizations getting involved because you have a bigger voice.
I agree, and I think public health is an important thing. I think I mentioned that to
Yeah.
OMA. I don't think it's on their current legislative list. They're
Right.
going for specific things.
How do
And
we
it,
get it
and the
on?
tobacco tax, that is one of the places that they were going to put the money. I think right now they're trying to just get Medicaid funding stable for the next biennium.
I understand that, but
Yeah.
that is the ongoing discussion through the 30 years of my career
Yep.
in public health. It's always healthcare before public health, and we know that,
It's all part of a package.
well, we know that most of health is not attributed to healthcare.
Right, right. Which is why ACP's got my heart, because they're really big on the social determinants of health and advocating for those. That's a good question. Public health funding is a good question. I would encourage you to I would encourage you to specifically talk to OMA. They've got they've changed their governance structure, so there's now a policy committee, and you can interact with them and talk to them about that. And that's exactly how emphasis and priorities come, is when people have a passion and they bring it to them. And I know OMA is really supportive of public health. Jim?
Marianne, you're an inspiration to us, and I mean that. And as a matter of fact, I'm going to pay my dues to these organizations with a smile, and I'm going to rejoin the ACP.
Oh, okay, success.
One of the things I notice is that the ACP gets a bunch of organizations together. You might speak to that, because we all have our little organizations. We go to Washington, D.C., and they say, you know, you're the lung doctor, and over there's the neurologist, and over here's the gastroenterologist. Speak to us about that a little bit. Just getting everybody together seems cool to me.
I think that they've always done that. They've always done some collaboration, and we're trying to do it at the state level right now with OAFP and OMA, et cetera. But I think that the urgency went up on November 9th, 2016, and healthcare professions came together, and that's where the group of 6 came from. And more, if you look at policy statements and letters to regulators, et cetera, there's a list that's 2-page long of healthcare associations primarily, but also other stakeholders. And ACP does a masterful job at that. Sometimes they're not the driver on a particular issue, so Title 10, it's ACOG, but ACP joined in, so did the family practice docs, et cetera. And there's like 10 organizations behind that. AMA brings other people in, but they tend to operate a little bit more independently. They're huge enough. I mean, they're like 250, 270,000 Sorry about that. So yeah, it's kind of meta, but it's actually a way of bringing the voices of medicine together, unified, and that has immense power in Washington and in Salem. So, you know, yeah. Somebody back there was going to ask? No? Any other questions?
More of a comment. There are two specific bills pushed by an organization here in Portland called Lift Every Voice. It's an ecumenical group on bans of assault weapons
Thank you.
and the capacity. I forget what they call it.
Oh, yeah, I heard that. I don't know a lot about
I
it,
can tell
though.
you more about it, but
Yeah.
there are two bills live right now.
Oh, good. I know there's a number of bills having to
Yeah.
do with weapons, and I didn't hear all of the numbers, but
There's like 10 of them.
yeah, and they're still consolidated all around the variations on the theme of those specific things. Oregon's way out in front in terms of regulating firearms in a way that respects Second Amendment rights but keeps weapons out of the hands of people who shouldn't have them. Anybody else?
Thanks so much. I'm kind of happy that at the national level, some of the stuff that you're talking about, like immigration and firearms things, like ACP goes to lobby. At a different time, I can imagine government officials saying, oh boy, here's some experts talking to us. We should listen to this. And they probably have something worthwhile to say. It seems like it's a different time now where it's only things only get determined by if you have the number of votes. If you can force something to happen. What ACP and these organizations, what muscle do they have as far as trying to force anything?
I think they have the power of numbers, and it is partly expertise. So some of this stuff that you're talking about are social determinants of health. And we have the expertise to speak out on public health and social determinants of health. Stuff like immigration, it directly impacts our members, the communities our members work in, and our students and residents. So we can speak out on it as that goes. You're right, in Washington, since November 2016 has been, well, increasingly before that, has become increasingly polarized. So one of the frustrations I've had going to Washington is watching how little they talk across that aisle. I sat in the balcony of the House of Representatives with some people a couple of times ago, and we looked down, and there's the aisle. Over on this side, there was a very diverse group of people, age, gender, race, whatever. On this side, honestly, it was primarily old white guys, you know? And there was distinct. And she said, I don't understand that. I said, well, that's the Republican side and that's the Democratic side. And see that aisle right in front of us? I said, that's the aisle they're always talking about. They weren't talking across the aisle. They wouldn't even talk to each other. And we'd go in and they'd say, oh, yeah, the other side doesn't want this, or, you know, we'll never get them to go there. It's beginning to loosen up. It is. The last time we were there, I was there in May with ACP and in February the AMA. They're beginning to talk to each other. And that's, I think, where we see movement. I don't think you can force anything, but what you want them to do is come together and collaborate. Honestly, the ACA was a process of about 18 months of committee meetings and bipartisan negotiations. It was an amazing piece of legislation in its crafting. We just need to get back to that. That's, I think, what the senator from Arizona with the brain tumor, McCain, that's what McCain wanted. I mean, he really said, you know, we got to get back to regular process. Thank you all. You don't have to stay. Hi, Lynn. Hi, John. Yeah, thanks. Yeah, I do, but it's buried. Lynn? Okay.
I'll be in touch with you. I'll need some help getting in the ACP.
Good.
Needed your picture at night. Send it out on Twitter.
Okay. And so I hope it's okay to put your face up there.